3, respiratory. This should be about at minimum 2-part video where we're going to talk about the disease, pathologies, and also some of just the normal functionings of the respiratory system. All right. So do we know that from chapter 15 that the airway is divided into what we call the upper and lower airway? For the purposes of this book, we're going to talk about anything above what we call the glottic opening. Remember, the glottic opening, or the glottis, is the space between the vocal cords. So anything above that, we're going to consider that upper airway right now, and anything below that, we're going to consider that lower airway. So starting with the upper airway, you have your nasopharynx, your oropharynx, your laryngopharynx, and then your larynx. Below your glottic opening, you have your trachea, your bronchial trees, your alveoli, and your lungs. Excuse me. Physiology. Now, the exchange of gases between the cells of the body and the outside environment is essential for respiratory physiology. We talked about that in chapter 15 when we done advanced airway management. So, for gas exchange to occur, air must move freely into and out of the lungs. This process is known as ventilation. So remember, ventilation is the mechanical movement of a gas in and out of the lungs. Once you have ventilation, then you have respiration. Now, remember, respiration is the actual exchange of oxygen and carbon dioxide between an organism and its environment. So respiration is the actual diffusion of the oxygen into the blood and the CO2 back into the lungs, and so on. 2 types of respirations that we're going to talk about is external respirations and internal respirations. So external respiration is the actual transfer of oxygen and carbon dioxide between the inspired air and the pulmonary capillary. So what that means is the ventilatory aspect comes in, we bring air into the lungs, or oxygen into the lungs. Due to diffusion, that oxygen, there's a higher partial pressure of oxygen inside the lungs compared to the partial pressure of oxygen in the blood system. So diffusion takes place, and respiration begins when that oxygen moves from the lungs into the vascular system through the pulmonary capillary membranes. Then, same concept in reverse for CO2, from the blood to the lungs. Next, you have internal respiration. Now, internal respiration is the actual transfer of oxygen and carbon dioxide between the capillary in the red blood cells and the actual tissue sites itself. So external respiration is taking place in the lungs and the pulmonary capillary membranes, and internal is actually taking place in the body inside the cellular level, or the tissue sites. Some factors that are essential elements for respiration include its structure and function of the chest wall. You want to make sure you're looking at your diaphragm, your ribs, your intercostal muscles, and your accessory muscles. Next, you have your control of breathing by the central nervous system. That's your medulla, your phrenic nerve, innervation of the diaphragm, your spinal nerves that innervate the intercostal muscles, and then your reflexes that prevent that overexpansion or overinflation. Remember, that's kind of like your stretch receptors. And then last, you have your acid-base balance, which mediates by the buffering system that also plays a very important role in your respirations. Because you remember back in chapter 11, and you remember back when we talked about acid-base and all that, one of the driving forces behind the buffering system is our respiratory system. And why that takes place is once our body notes a change in the pH, whether it's increase or decrease, remember, decrease is acidotic, increase is alkalotic, we can alter our respirations because that's a relatively quick way to either, one, expel CO2, which increases our pH, or one, we can slow down respirations, which holds on to CO2, which lowers our pH, whichever one our body deems is necessary at that point. So the pathophysiology. So pathophysiology, variety of problems can affect the pulmonary system's ability to achieve this gas exchange. Now we know that gas exchange must occur to provide for the cellular needs and the excretions of the waste. So this is nothing new to us. We understand this 100%. However, there are specific disorders responsible for respiratory emergencies, including those that are related specifically to ventilation versus diffusion and perfusion. Risk factors associated with development of respiratory diseases are anything from like your intrinsic factors such as asthma, obstructive pulmonary disease, or obstructive lung disease such as COPD and so on, and then cancer. You can also have them intrinsic related that are cardiac in nature such as pulmonary embolisms or pulmonary edema, secondary congestive heart failure. Now, some extrinsic factors really just play on top of those intrinsic factors, and that's like COPD exacerbation secondary to smoking or pollutants around you in the air and stuff like that. All right, so the ventilation aspect in the pathophysiology world. So like we discussed earlier, ventilation is nothing more than the process of actually moving a gas in and out of the lungs. Excuse me. So in order for this to occur, we must have neurological control. That's what initiates the ventilation. The nerves between the brainstem and the muscles of respiration. You must have a functional diaphragm and intercostal muscles, because that's how we change. Remember, our diaphragm drops down, our intercostal muscles expand out or contract and go out whenever we take a deep breath in, and that drops that pressure, creating a negative pressure inside the chest, pulling air in. And in order for that air to come in, we got to have that patent upper airway. We got to have functional lower airway, and our alveoli must be functional and not collapsed. I'm going to go back to chapter 15. Remember, the easiest way to look at your alveoli is that's your actual functional units of respiration. So specific pathophysiologies associated with ventilation include upper and lower airway obstructions, chest wall impairment, whether it be from trauma or medical, lung tissue diseases, trauma relating to neurological control related to to medical processes. The emergency treatment for ventilation problems include ensuring we have an upper airway that's clear, and we're providing positive pressure. We're providing ventilations as needed, and also don't forget that making sure that we're increasing that partial pressure of oxygen in the lungs by providing that supplemental O2. Diffusion. Now, diffusion should be something that's already beat into your head. You should know this. It should be word vomit at this point. What is diffusion? It's when you're going from an area of higher concentration to lower concentration. So diffusion is the process of gas exchange. This gas exchange occurs between the air-filled alveoli and the pulmonary capillary beds, and is driven by the tendency of this gas to want to move from an area of higher concentration to an area of lower concentration. This exchange occurs until this concentration is equal. So for diffusion to occur, you must have the following intact. You must have an alveolar wall and capillary walls that are not thickened. And you also must have the interstitial spaces between the alveoli and the capillary wall cannot be enlarged or filled with fluid. So specific pathophysiologies associated with diffusion include inadequate oxygen concentrations in the ambient air, alveolar disorders, interstitial space disorders, and capillary bed disorders. And we're going to talk about those here in just a little bit more in detail. And some of them you probably already know. You just don't understand what I'm talking about right at this moment. So some emergency treatment for diffusion processes include providing high concentrations of oxygen. Treatment is also directed at reducing the inflammation or the tissue or the fluid that's involved in that interstitial space. Perfusion. So perfusion is the circulation of blood through the lung tissue or the capillary beds. For this process to occur, the following must be intact. One, we must have adequate blood volume. We almost must have adequate hemoglobin concentrations in the blood, because what's hemoglobin do? It carries the oxygen, right? The pulmonary capillaries are not occluded, i.e. pulmonary embolisms and so on. And then you got to have an efficiently pumping heart. We must make sure that we got that adequate amount of blood, we got the adequate amount of hemoglobin inside the blood, and we got to make sure that the blood can get there with no obstructions, and we got to make sure we got a good pump to get it there. Some specific pathologies associated with perfusion include inadequate blood volume, impaired circulatory flow, and capillary wall disorders. Emergency treatment for perfusion problems usually ensure that we got a circulating blood volume and hemoglobin levels are adequate, as we've already said. And we can also make sure we got optimization of that left-sided ventricular function of the heart. And again, a lot of times with your perfusion and excuse me, with respiratory problems, it's either going to be a blood issue or it's going to be a pump issue. All right, some unknown pulmonary diagnosis. So if the patient's diagnosis is unknown, paramedics should try to determine whether the primary problem is either ventilation, diffusion, or perfusion, or is this a combination of multiple ones. Care for a patient with unknown pulmonary diagnosis should be focused on the specific disorder responsible for that particular respiratory emergency at the time. Ventilation disorders are managed by assisting the patient, making sure that we got an appropriate open airway, and using mechanical means such as your modified jaw thrust, your head tilt chin lift. We're going to relieve any airway obstructions, clearing the airway of secretions, blood, vomit, dirt, teeth, whatever it might be, using airway adjuncts as needed. And so remember guys, we're not just saying when we say airway adjuncts, we're not just talking strictly about intubating. Your airway adjuncts is your nasal airways, your OPAs, your supraglottic airways, your retroglottic airways, so on. All right. You also need to follow up with manual or mechanical ventilations as needed. Figure out, is this related to a drug issue? So remember, a common thing that we run into today in the field is opiate abuse. So is this an opiate overdose? Because what is an opiate? It's a central nervous system depressant. So if this is an opiate possible cause, then we want to give that reversal agent, which is Narcan. All right. So for diffusion disorders are treated by improving gas exchange between the alveoli and the pulmonary capillary network system. For example, you can the easiest thing that comes to mind, to be honest with you, is pressurization. And that's your NIPPVs, so your non-invasive positive pressure ventilation. So you're looking at CPAP or BPAP. Now remember, CPAP is continuous positive airway pressure. That is what we're very familiar with in this area, or in the pre-hospital setting for us. However, in the hospital settings or in some of your critical care transport settings, you'll see BPAP. Now BPAP is nothing more than bi-level positive airway pressure. So what the difference really, to be honest with you, continuous CPAP, continuous positive airway pressure, it's a constant pressure both in the inhalation and exhalation phases of breathing. BiPAP, or BPAP technically is how you say it. BPAP is a bi-level, meaning the pressure on inhalation and the pressure on exhalations are different. And so that has to be controlled. That's why you usually don't see that in our standard pre-hospital settings. Excuse me. Some medications that you might use for diffusion would be nitroglycerins, okay, and that works in conjunction with your positive pressures, so pushing that fluid back in so that we can now kind of decrease that fluid between the lung tissues and the lung vascular system itself. However, if you are dealing with a perfusion disorder, they're managed by improving that circulating blood volume through the lung tissues. So IV fluids, but remember now, IV fluids themselves don't have oxygen carrying capability. So if this is a blood issue due to hemorrhage or just anemia or something like sickle cell anemia, you want to make sure that we can get that patient somewhere so they can get some product in them so that we can increase their oxygen carrying capability. And then also using our medications in conjunction with our heart failures to make sure that we are getting as much bang for the buck as we can on that heart failure patient. And that's like your strict beta-1 inotropic medications such as, dobutamine and so on. Regardless of the specific disorder, all patients with respiratory compromise will receive high concentrations of oxygen and ventilatory support as needed. Now, I know National Registry gets on this, hey, the longest sats are 95 and above, don't really need to put them on oxygen. Again, look at your patient, okay? Treat your patient you have in front of you. If that patient's having a true respiratory emergency, what's the easiest way we can ensure diffusion? Okay, remember what diffusion is. Higher concentration to lower concentration. So if we breathe in 21% oxygen every time we breathe in, then it only makes sense. If that's not working, let's increase the amount of oxygen in the lungs, which is going to increase the amount of partial pressure, and that's going to kind of force it through. And then we can add adjuncts to that, such as the pressurization, like CPAP, BiPAP, and so on. Respiratory failure. All right. So as paramedics, we see many patients who have respiratory distress. Now, there's a difference between distress, failure, and obviously arrest, right? So most of our patients that we run into have illnesses that are not really life-threatening. Now, I'm not saying that asthma is not life-threatening. I'm not saying that COPD is not life-threatening. That's not what I'm saying. What I'm saying is treated appropriately and timely, they're usually reversible, or the current emergency at that time is reversible. However, it's when we allow that patient or that patient allows themselves to get so far down into that hole that it's hard to bring them back. However, in a number of small cases, this respiratory distress can turn into respiratory failure. And all respiratory failure is a syndrome in which respiratory system fails in one or both of its gas exchange functions, whether it's oxygenation or carbon dioxide elimination. It is crucial to recognize and intervene quickly when faced with respiratory failure. Your book says here that the mortality of these patients can exceed 30% once they've moved from distress into failure. And in fact, patients admitted to the hospital with respiratory failure are about 4 times less likely to be discharged alive than those with cancer or heart disease. Now, again, that's your book. I have nothing to relate on that. I do know from not personal experience, but past experiences with these patients. You've watched people go from respiratory distress, respiratory failure, and then respiratory arrest, and ultimately cardiac arrest. And that's a bad thing. Most of the time, though, like I said, it's because we're getting there on the backside. Not necessarily what we did. We're getting there on the backside. So patients can have some different types of failure. You have what we call hypoxemic respiratory failure. And all that means is there's a decreased amount of partial pressure oxygen in the arterial blood supply. Now, it means technically per your book or per some other literatures, that's a PaO2 less than 60 millimeters of mercury. Granted, we're not going to be able to have that in the back of the ambulance. We're not going to know that at that particular time. So what we're looking at that point is kind of our SpO2s. Is our SpO2s, or SaO2, so to say, level less than 90% and staying less than 90%. Then you have ventilatory failure. Well, it's kind of self-explanatory what ventilatory failure is. Remember, ventilation is the process of moving air in and out, right? So ventilatory failure is when we have a partial pressure of CO2 exceeding 50 millimeters of mercury inside the arterial blood at any given time. Again, we don't have that ability to check that arterial blood, but we do have those end titles, and we do have what? Our eyes, and we have our mind. We can look at this patient. We can understand the pathology of what's going on with this patient. We can expect to see what's taking place inside the body. Now, you can have both hypoxemic respiratory failure and ventilatory failure, which will then cause you to have a drop in your pH, which causes a cascade of events because your body starts trying to correct itself, and all it's doing is actually making itself worse because it's requiring more oxygen than it can provide itself. Some patients with respiratory failure at the outside of the call, whereas some decline during the pre-hospital setting, become very fatigued, and they'll start going hypoxic and hypercapnic. So you'll start watching this patient, they'll start getting fatigued, they're going to start slowing their respirations down. They're not going to be taking as deep of a breath, so therefore they're not going to be having the volume nor the rate to maintain that oxygen requirement. So they're going to start going down. As they start going down, you're going to start seeing CO2 levels rise. Along with some other patients' underlying illnesses, some key signs of impending respiratory failure, including a decreasing SaO2 level despite oxygen therapy. Now, that's when you're popping them on that SpO2 monitor and they're like at 84%. They have no respiratory history that you know of, and now you've got them on 15 liters non-rebreather, and that SAT's just steadily going down. Increasing end-tidal carbon dioxide level. I don't have to beat that in your head. You should already know that. You know how keen I am on that. Evidence of fatigue. We've all seen that patient that's just tired. That's the only way to put it. Then you have nasal flaring. Decreased consciousness. Remember what I told you from the very beginning in the airway section when we started. A patient that has altered level of consciousness or altered mental status, confusion, anxiety, or anything like that, always consider it hypoxic in nature until proven otherwise. Then you have your nasal flaring, self-explanatory there. Your seesaw ventilations, that's where you're looking at belly. You get that belly rise and fall with the chest wall. Arrhythmias, what's the first thing the heart's going to do when it doesn't have oxygen? It's going to start showing out, right? And then cyanosis. Failure to intervene during respiratory failure will typically lead to respiratory arrest or cardiac arrest. Usually, NIPPV turns these patients around relatively quick. Again, now you got to understand what this non-invasive positive pressure ventilation is and what it's going to kind of do to the normal concepts of breathing. So you have to kind of know what to look for and how to assess these. And that will be taught a little bit more in depth later on. However, don't just use just that NIPPV. You've got other not other airway, but you got other medication adjuncts that you can use in conjunction with those. If we can put a patient on NIPPV, usually we can decrease their mortality rate compared to intubating that patient. Usually when a patient's in respiratory failure secondary to like an illness such as asthma or COPD or something like that, if it gets to the point where we go straight into intubating them and all that, we don't try other means, it just makes it very difficult for that patient. All right, so assessment findings. So the general impression of a patient can be made in the primary survey. The main focus of the primary survey is to detect and manage any life-threatening conditions with airway, breathing, and circulation. The actions in initiating resuscitative measures take priority over a detailed assessment. That should not be anything new to you guys right there. So some signs of life-threatening respiratory distress in adults are as follows. Alterations in mental status, goes back to what I just said. Severe cyanosis. Stridor, remember what stridor is. That's indicative of an upper airway complication. Inability to speak one or two words without dyspnea. We call that 1 to 2 word dyspnea. Tachycardia. That's usually that dead giveaway, right? Pallor and diaphoresis. And then you can have retractions and or use of accessory muscles to assist with breathing. And we've all seen that. You've seen those retractions and those intercostal muscles. That's more seen in your smaller people, obviously. In your bigger people, you can start looking at those sternoclavicular muscles right up here, and you'll start seeing them suck in around their neck. Another thing you can watch is you might watch your patient start having like pursed lip breathing. And what pursed lips do is they're almost trying to mimic that PEEP. They're trying to keep that pressure inside the lungs by doing that. So, obviously, if you see the pursed lip breathing, automatically start kind of throwing CPAP out there pretty quick. A quick assessment of the lungs may be indicated in the primary assessment because I know you got airway, breathing, circulation, and then technically lung sounds doesn't come in until you get into your detailed assessment. But as paramedics, we're going to learn how we can multitask. We're going to have to be able to do this relatively fast. So we can actually, if we know this is a respiratory illness or an emergency and we know it's related to the breathing aspect of it, and this could be a cause of it, then let's go ahead and listen to lung sounds. And last but not least, the position of this patient. If this patient's sitting in a tripod, that nose stuck up in the air in the sniffing position, they're trying to get that airway in line as much as they can to decrease the restriction of airflow into the lungs, that's another dead giveaway. And also treating a patient with changes in position is very important, and it's something that we need to understand also. All right, so your focused history. We're not going crazy in depth in the focused history aspect of this. You should understand what a focused history is. You're going to ascertain your chief complaint. You're going to obtain your focused history using your OPQRST. Remember, O is onset, P is provocation / palpitation, Q is quality, R is regions or radiations, and then S is severity, T is time. And as paramedics, you're going to learn how to tailor these questions in your OPQRST to actually start answering some questions that you're going to ask later on. So you're kind of killing two birds with one stone when you do that. And obviously, you're going to obtain a medical history to make sure that this is nothing new to the patient, or is this an exacerbation of something chronic for this patient. And of course, with your medical history comes your medications. And remember, you want to make sure you look good at your medications, because a lot of times, especially when patients are on cardiac medications, they can have some medications that interfere with our treatment that we provide to our respiratory patients. So just say like the patient's on a non-selective beta blocker and we give them albuterol. Well, we know they're taking a non-selective beta blocker, which means that they just take a beta blocker that goes in and blockades all beta receptors. Well, we're fixing to give them albuterol, which is a beta 2 receptor agonist. How are we going to do that? Because they're already on a medication that's blocking that. Now, I'm not saying you're not going to give it to them. I'm just going to say just be ready for your medication and not to work or as effectively or as fast as you're used to seeing it work. Your secondary assessment. So your secondary assessment should be guided by the paramedic's general impression of the patient and that patient's particular chief complaint at that time. As a part of the secondary assessment, our paramedic should note the patient's position, their mental status, their ability to speak, respiratory effort, skin color. So this is stuff, if you notice, that we really already kind of started getting in the prior section of this, but we worked our way into it. You're also going to start getting you some vital signs. Excuse me. You're going to look at your pulse rates, your blood pressures, your respiratory rates. Now also go back and remember your shock states. So what is shock? It's decreased oxygen level or decrease oxygen at the tissue sites, right? Hypoperfusion. You got to have oxygen. So if this is shock is going, or respiratory illnesses are going to kind of present just like a shock patient would. You're going to have that increase in pulse rate because the heart's trying to make sure we're getting enough blood to the lungs and then circulating that blood throughout the body system. Your blood pressure is going to be slightly up because it's trying to increase that pressure so we can move that blood throughout the system. Your respiratory rate is going to be elevated because we're trying to get more oxygen inside the lungs. Your volume, same concept, is going to be more because we're trying to get a larger amount of oxygen inside the lungs. Like I said, you're going to inspect the patient and look for that pursed lip breathing, grunting, nasal flaring, or the use of accessory muscles. If you see this pursed lip breathing, grunting, nasal flaring, use of accessory muscles, guys, please don't play around with these patients. They are sick and they're asking for help. Okay, like I said, that pursed lip breathing, what they're doing is they're almost giving themselves, they're increasing their PEEP in their lungs to keep it open. Grunting is they're having to use their muscles to actually force air inside. Nasal flaring, same concept, and accessory muscles, same concept. They're having to use this extra muscles that's not usually utilized for breathing. They're having to use it to try to draw in as much oxygen as possible. The patient should be questioned about sputum production. We want to make sure that if they are coughing up anything, as nasty as it sounds, what does it look like? Is it yellow? Is it green? Is it clear? Is it blood tinged? Is it blood streaked? There's a difference. Don't just say, well, have you noticed any blood in your sputum? Because a blood streak and a blood tinged are two different things. Blood tinged means that's actually probably blood inside the pulmonary system. However, that blood streaked is usually due to like just a large amount of coughing and got that irritated passage as that mucus is passing by. Another thing you want to do is check and make sure this is not a cardiac-related injury. So that's where your thick, frothy sputum, bloody tinged sputum, and all goes in. The patient's neck vein should be evaluated for JVD. Or, do they have engorged neck veins? If they do, that's indicative of right-sided heart failure. And it could also indicate a severe case of left-sided heart failure that's then progressed over to right-sided heart failure also. We want to inspect the patient's chest for injuries or any indications of chronic diseases such as a barrel chest from that long-standing emphysema. So, you got that big barrel chest. Those are usually pretty thin-framed people because they'd rather breathe than eat. I can understand that too. Other components of a chest examination include noting the accessory muscles and that retractions, like we said earlier. The patient's extremities can be assessed for peripheral cyanosis, looking for pitting edema, clubbing of the fingers, asterix, and carpal pedal spasms. Now, the peripheral cyanosis is caused when a large amount of the hemoglobin in the blood is not carrying oxygen. So therefore, we start losing that oxygen. We all understand what cyanosis is, right? The pitting edema is indicative of heart failure. And again, it depends on the stage of heart failure, on how much of that pitting edema you're going to see. And then you got your clubbing. That's an enlargement of your fingertips. If you look on page 909, figure 23-2, you'll see that. And you can see those in two types of patients. You can see them with chronic congenital heart diseases, or you can see it with long-standing obstructive pulmonary diseases. Then you have your asterix. That's a flapping tremor. When these patients get short of breath, they'll have a flapping sensation in their hand. And also carpal pedal spasms. And that's usually seen with like hyperventilating patients. When we drop those CO2 levels, you'll see them, they'll pull them hands in towards their forearms, their fingers will lock up, and all that. And that's usually secondary to, like I said, decrease in CO2 from hyperventilation. Physical findings in a patient with respiratory disease should be documented well and should be ready to present to the receiving facility, because remember, everything that you treat and note inside your assessment and transport is very crucial to how that hospital is going to treat and assess that patient also.